So next is otitis media with effusion. So this is also known as secretory otitis media, mucoid otitis media, or also glue ear. Okay. So what is this means? It is collection of serous fluid in the middle ear. Okay. So there is accumulation of non-purulent. Okay, it is specific non-purulent effusion in the middle ear cleft. Okay, and sometimes effusion is thick and viscid, and sometimes it may be thin and serous. Okay, and the fluid is nearly sterile, and it is commonly seen in the school-going children. Okay. So while discussing about the pathogenesis of this otitis media with effusion condition, there is first one is malfunctioning of the eustachian tube. Okay, so the eustachian tube is malfunctioning here. Eustachian tube fails to aerate the middle ear, and also it is unable to drain the fluid. Okay, so that is the first, and second one is there is increased. First is decreased drainage, and second is increased secretory activity of the middle ear mucosa. Okay, there is increased number of the mucus or the mucus secreting cells. Okay. So next is about the malfunctioning of the eustachian tube. So first there is malfunctioning of the eustachian tube, and the main cause for this malfunctioning of eustachian tube is first one is adenoid hyperplasia. We know that adenoid, that is a midline structure. So due to the hyperplasia of this adenoid, this will lead to the blockage of the eustachian tube. Okay, and this is mainly seen in the children, and it will disappear by 25. Okay, and this is mainly leading to bilateral serous otitis media. Okay, because it is a midline structure and it is blocking both the eustachian tubes. Okay, and also second cause is chronic rhinitis and also sinusitis, which leads to allergy, and also chronic tonsillitis. Chronic tonsillitis, that is enlarged tonsils, which mechanically will be obstructing the movements of the soft palate and also interfere with the physiological opening of the eustachian tube. Okay, so first one is adenoid hyperplasia, then chronic rhinitis, sinusitis, and chronic tonsillitis. Okay, that is mechanically, that is more like obstructing the movement of soft palate and interfering with the physiological opening of the eustachian tube. And fourth one is the benign and malignant tumors of the nasopharynx. Okay, nasopharynx benign like malignant tumors വരുന്നത്. This case should always be excluded in the unilateral serous otitis media in adult. Okay, അപ്പോൾ ഇങ്ങനെ benign and malignant tumors of nasopharynx നമ്മൾ എപ്പോഴും എന്താണ് യൂണിലാറ്ററൽ സീറസ് ഓട്ടിറ്റിസ് മീഡിയ കേസസിൽ നമ്മൾ എക്സ്ക്ലൂഡ് ചെയ്യണം. ഓക്കെ, കാരണം കൂടുതലും യൂണിലാറ്ററൽ സെറസ് ഓട്ടിറ്റിസ് മീഡിയ കേസസിൽ ബിനൈൻ അല്ലെങ്കിൽ മാലിഗ്നന്റ് ട്യൂമേഴ്സ് ഓഫ് നൈസോഫാരിങ്സ് നമ്മൾ എന്ത് ചെയ്യണം, സസ്പെക്ട് ചെയ്യണം. ഓക്കെ, നെക്സ്റ്റ് ഈസ് ഡ്യൂ ടു പാലറ്റൽ ഡിഫക്ട്സ്. പാലറ്റൽ ഡിഫക്ട്സ് എന്ന് പറയുമ്പോൾ ക്ലെഫ്റ്റ് പാലറ്റ് ആവാം, ഓർ പാലറ്റൽ പാരലിസിസ് ആവാം, ഓർ ഡൗൺ സിൻഡ്രോം. സോ ദിസ് ആർ ദ മെയിൻ കോസസ് ഫോർ ദ മാൽ ഫംഗ്ഷനിങ് ഓഫ് ദ യൂസ്റ്റേഷ്യൻ ട്യൂബ്. Okay, so next reason is allergy. Okay, allergy means like seasonal allergies avam, that is to inhalants or the foodstuffs. Okay, which is very common in children. Okay, so this allergy will be obstructing the eustachian tube by edema. Okay, and this will lead to increased secretory activity in the middle ear mucosa and acts as a shock organ in such cases. Okay, so in allergy cases there will be mainly due to edema only this eustachian tube obstruction occurs, and also there will be increase in the middle ear secretion. Okay, so that's a two thing happens in case of allergy. So it is also a reason for increased secretion. Okay, and second is unresolved otitis media. Okay, so there was a case of acute otitis media, and I give antibiotic therapy, but the inadequate antibiotic therapy, okay, in acute suppurative otitis media will inactivate the infection, but there will but fail to resolve it completely. Okay, so still there is an infection lingers on, and this acts as a stimulus for the mucosa to secrete more fluid. Okay, so here there will be more fluid due to the stimulus due to the mucus secretion. Okay, there will be increase in the goblet cells, mucus glands also. And fourth reason is a viral infections, mainly the adeno and the rhinoviruses of the upper respiratory tract will invade the middle ear mucosa and stimulate to increase the secretory activity. Okay, so I said first one is the malfunctioning of the eustachian tube, and others are the secretory pathogenesis. Okay, that only I said. Okay, next is about the clinical features of first the symptoms. Okay, mainly these symptoms are seen in the children of 5 to 8 years of age, and the main symptoms are first one is hearing loss. Sometimes the only presenting symptom will be hearing loss only. Okay, and it will be insidious in onset, and rarely it will exceed above 40 decibel. Okay, and sometimes the deafness may be unnoticed by the parents. Okay, and accidentally be discovered during the audiometric screening test. Okay, so first symptom is hearing loss, and second one is delayed and defective speech. So we know that there is hearing loss, therefore there will be delayed development of speech, and sometimes the speech will be defective. So that is delayed and defective speech will be there. That is mainly due to the hearing loss. Okay, and the third symptom is mild earache will be there. Okay, there is history of upper respiratory tract infection, plus there will be mild earaches also will be there. Okay, that is, and along with these symptoms when we are doing we will be getting something otoscopic findings. Okay, otoscopic findings, that is the tympanic membrane will be often dull and also opaque. Okay, will be opaque and also dull with the loss of light reflex. Okay, sometimes it may be like different colors, sometimes yellow, green, gray or bluish in color, not green, gray, yellow or bluish in color. Okay, and we can see thin leash of blood vessels, along the handle of the malleus or at the periphery of the tympanic membrane. Okay, and this is differ from the marked congestion of acute seborrheic otitis media. Okay, and the tympanic membrane may show varying degree of retractions also. Okay, sometimes it may appear full or slightly bulging or in the posterior part due to the effusion. Okay, sometimes it will be appearing full or slightly bulging in the posterior part. Okay, that's about its retractions. And while the fluid, can we see the fluid level and the air bubbles? Okay, we can see the fluid level and air bubbles only if the fluid is thin and the tympanic membrane is transparent. Okay, then we can see the fluid level and air bubbles. Okay, and in these patients, when they do the Valsalva maneuver, this will produce a crackling sound. Okay, and the mobility of the tympanic membrane in this case is restricted. The mobility of the tympanic membrane is restricted, and why the bubbles seen means here, when the air enter into the fluid, only the bubbles can be seen. Okay, so these are the otoscopic findings. So next is about the investigation findings. Here we will be doing, here the patient is coming with hearing loss. Okay, so first he should do the hearing test, first the tuning fork test, and while doing the tuning fork test, you get the result like there is conductive hearing loss. Okay, next you should do the audiometry. Audiometry also there you get that there is conductive hearing loss of 20 to 40 decibel is there, and there is also associated sensory neural hearing loss is there. That is, here the fluid is pressing the round window membrane also. Okay, and the sensory neural hearing loss that disappears then when with evacuation of the fluid. Okay, so while here we are doing the Rennes test and Weber's test, here the Rennes test is negative. That is, here the bone conduction is greater than the air conduction. That is, here there is conductive hearing loss is present. And while doing the Weber's test, that is lateralized to the affected side. Okay. Okay, next, while doing the impedance audiometry means it is a objective test, that is useful in infants and children. Impedance audiometry, here while doing, the presence of the fluid is indicated by reduced compliance. Okay, and we get a flat curve or a dome shaped curve. Okay, which with a shift to the negative side. So that is the impedance audiometry. And last, we should take an X-ray mastoid or CT temporal bone, and there will be clouding of air cells of the mastoid due to the fluid. Okay, so these are the investigation. Next is the treatment. Main aim of treatment is to remove the fluid and the prevention of its recurrence. Okay, that is the treatment aim. Okay, so first is the medical treatment. Here the medical treatment, first you should give the decongestants. Okay, here the decongestants mainly given for reducing the edema of the eustachian tube. Okay, you can give topical decongestants in the form of nasal drops, nasal sprays, or you can give systemic decongestants. Okay, and second, you should give anti-allergic measures. Okay, like antihistaminics or steroids can be given. Okay, that is in case of allergy, and if possible, you should find out which is the allergen and should avoid it, or desensitization can be done in case of that. So these are the anti-allergic measures. And next, last is the antibiotics. Okay, antibiotics mainly useful in case of upper respiratory tract infections or unresolved acute seborrheic otitis media. Mainly antibiotics are useful. And third is the middle ear aeration. Okay, here what is the main problem? Here the main problem is the eustachian tube blockage, and there is decreased drainage. Okay, and also there is decreased aeration of the middle ear cavity. So here we are forcing the air from the nasopharynx into the middle ear, that is through the eustachian tube, by increasing the pressure in the nose and the nasopharynx. That is by doing repeatedly the Valsalva maneuver. Okay, and sometimes we can do pulseration or eustachian tube catheterization, and insufflation hand can also be done, and this helps to ventilate the middle ear and also increase the drainage of the fluid. Okay, and children can be given chewing gum to encourage repeated swallowing, which also can open the tube. Okay, these are the medical managements. And next is the surgical management. So if the medical management is not helping, or when the fluid is thick, we should do the surgically remove the fluid.